Okay, this is the recorded lecture for chapter 38 and 39. I'm going to record chapter 38 and then I'm going to post it and then I'm going to go in and record 39. So there'll be two separate recordings that you need to listen to. I first want to start though with saying what a good job you guys did at the flu shot clinic. We did, I don't know the exact numbers, but you guys did over 270 injections. So that was great. I do want to thank you and commend you for your teamwork and your assertiveness and stepping up and helping during the transition of the two groups. I really appreciate that. It was kind of like, in addition to switching out the students, we kind of got slammed with patients during that time. So it was kind of chaotic, and you all just kind of stepped up and just jumped in and helped, and I really appreciate that. And then also the students, the last group who stayed a little longer than 10:30 to help with those straggling patients who wanted flu shots, I really appreciate you guys staying later. So you did very well. Something was brought to my attention that I do want to review with you guys. I don't know if the person who reported this to me does not know whether there were students that were recapping needles after giving the injection to the patient, or if the students were seen recapping needles after they were filling the syringes. So, and I was asked about that. I don't know if it was by this group or my other group on Wednesday. I can't remember, but I was filling syringes and some students were asking me about recapping. So, and I don't know if I didn't explain myself well or what, but here it goes. So when you are filling syringes with medications and you do not have needles that are safety needles, or you're not switching needles after you're filling the medications, you can recap. And that's what we were doing, and that's okay. And I don't know if we were seen doing that and a patient reported it or what. Or if students were recapping needles after giving the injection. So in most situations, in most facilities, you will have the needles with the safety feature to close the needle off where you do not have to recap, and that's great. So when you fill a medication with that kind of needle, you can fill the medication, you can either recap it and take it and give it to the patient, or you can engage the safety feature, take the needle off and put a needle on. You could do that. We could have done that as well. We could have filled the syringe with the medication, taken the needle off, and then put a new needle on. But the way we did it was fine as well. However, when you give an injection, I don't care if you have safety needles or if you don't have safety needles. You do not recap after giving an injection. You do not recap after giving an IV push medication. So you either give that medication and immediately engage the safety feature, or immediately discard that syringe and needle into a sharps. You do not ever recap after giving the injection to the patient. Okay, so that's been clarified. Now, oxygenation and tissue perfusion. So the other thing I would like to reiterate, I said this in lab on Friday, is when you're giving oxygen to a patient, you will have an order, and the order will read something along the lines of oxygen. It will actually say O2 at 2 to 4 liters, nasal cannula, PRN, SATs greater than 90, 95, whatever the physician orders. So if you go into a patient room and you put on the nasal cannula and the patient says, I don't like this doesn't feel comfortable, is there any other thing we can do? The answer is really kind of no. If the physician ordered a nasal cannula, the patient gets a nasal cannula. Now there are some things we can do to try to make that more comfortable, and one of them is putting it over the head like we practiced. And again, apparently St. Pat's has a policy where you're not allowed to do that. Community does not have such a policy as of yet. So the other things that we can do is we can trim the nasal prongs on the cannula. But you want to be careful when you trim those. You don't want to trim them too short where they just meet the introitus of the nares. So in that case, then the oxygen cannula will be able to slip around, and then they won't be getting the oxygen through their nose like they should be. So if you trim that, you just need to just trim it just a little bit, and trim it so that the prongs are still going into the nares. The other option that we have is we do have those little foam sleeves that you can put on the tubing that goes around their nose, and that will help. If you don't have those foam sleeves to put on the tubing, you can get some 2x2s or 2x4s or 4x4s or whatever, and wrap the tubing that goes over their ears that's making it uncomfortable. If the patient needs more oxygen than can be supplied safely through a nasal cannula, then the physician will order a mask. Or you'll call the physician and you'll say, hey, like I'm having to run more than 4 liters or more than 5 liters to get this person's SATs above what you've ordered. I would like to switch to a mask. So you would have to get the order to switch to a mask. Okay. All right, here are your learning outcomes for the chapter. So please do review your normal structure and function of oxygenation. If you have any questions, let me know. But as far as altered structure and function, so of course we have to breathe in the air, the oxygen. So we have to have the ability to breathe in. So our breathing structures have to be healthy. Our alveoli, our lung tissue, has to be healthy in order to do the exchange of carbon dioxide and oxygen. Our pulmonary vasculature needs to be healthy in order to have the appropriate pressures for oxygen, for blood to flow through. The blood from the right side of the heart, the deoxygenated blood, needs to be able to flow through and pick up the oxygen, and then the oxygenated blood needs to be able to flow back to the heart. Now, the heart also needs to be functioning appropriately. We may have healthy lungs and all that kind of stuff and have good oxygen exchange and carbon dioxide exchange, but if our heart isn't pumping for whatever reason appropriately, it's not going to get, 1, the oxygenated blood to the tissues, or 2, it might not be getting the deoxygenated blood back to the heart or be able to pump it to the lungs. So there might be a problem with our heart as well. Now, as far as our heart is concerned, we need to be able to have the appropriate electrical conduction going on in the heart. So it's the electrical conduction that stimulates the heart to contract. It's the actual muscle that contracts. So there's 2 avenues there. So if our electrical system isn't working correctly, telling our heart to pump appropriately, then we have a problem with oxygenation. If our electrical system is working fine, but our heart muscle is not working fine, if our coronary arteries are not supplying the heart muscle with the oxygenated blood it needs to function, then we're going to have a problem as well. And then also we have the structural anatomy of the heart. So if our valves are not working appropriately, then we're not getting the blood to the different chambers of the heart and passing through the heart, and so forth and so on. So there's all those avenues that could be presenting a problem. So when we do our assessment, of course, we're going to look at our vital signs. We're going to look at our oxygen saturations. We're going to assess our heart rate and listen to our heartbeat. We are going to assess our breathing patterns. What do our breathing patterns look like? Are we using accessory muscles to breathe? Are we using postural positioning so that we can breathe adequately? Do we have any dizziness, any altered level of consciousness? Those kind of things are going to direct us to possible oxygenation problems. Okay, so what are some of the respiratory problems that we could have that would affect oxygenation? So the big group of the chronic obstructive pulmonary disease, or COPD, those are disorders of the lung. And the emphysema and chronic bronchitis are two of the big, two different diagnoses the patient can have that would affect oxygenation. So with emphysema, we have a problem with our alveoli. So basically, in a nutshell, what happens with emphysema is those alveoli are damaged. They do not have the elasticity that they once normally had to expand and contract. And what happens is the gas exchange is not able to occur at the alveoli level. What happens is air gets trapped in those alveoli and in the distal portions of the lung tissue, and so they're not able to exhale out their air, which will inhibit the amount of air that they can breathe in. Okay, so then they have limited ability to exchange carbon dioxide and oxygen. And then in addition to that, there's that mucus that also is built up on the lung tissue that inhibits the exchange of gases. So here are your causes for emphysema, smoking being the biggest culprit, but also any environmental exposures or a family history as well. Okay. Chronic bronchitis, different than the bronchitis you get once in a while during the winter season. Chronic bronchitis, these people have bronchitis for extended periods of time. This is the buildup of the mucus. They're not able to clear the mucus. They have a chronic cough, a productive chronic cough. And here are your risk factors. So smoking, environmental pollutants will cause people to have chronic bronchitis. Asthma is another big one. There's a lot of people who have asthma, childhood and adult asthma. Asthma is a problem with bronchospasms, airway spasms, and obstruction. These people will complain of a cough, tightness, or spasming of their airways. We will hear on auscultation wheezes, and this will affect a person's ability to breathe in adequate amounts of oxygen. Okay. Okay, so as asthma can be, or spells of asthma, the bronchospasms that occur can happen because of something stimulating the airway. So allergens, pollutants, even stress can cause an asthma attack. Certain medications can cause asthma attacks. And so they have the bronchospasm, the mucus, the edema in their airways. So there's several other things that can cause respiratory problems. Pneumonia, atelectasis, TB. So a patient gets pneumonia, it's an infection of the lung, and of course that will cause mucus production, a cough, airway damage, and atelectasis is a result of some sort of insult to the lungs. So it's a collapse of those lower alveolar sacs. Those sacs, they do collapse, and so they're not able to expand and blow off CO2 and blow off or take in oxygen. So a lot of times we will see these in patients that have had some sort of surgery where they're not breathing as well as they should be. Those lower airways, they can get fluid on them, and they can collapse and create an atelectasis. Okay, so this is different than a total, like a pneumothorax. So atelectasis and pneumothorax, although they are they seem like the same. Atelectasis is those lower um, um, airways, the alveoli at the lower portion of the lung. A pneumothorax is where there is fluid in the pleural sac of the lung, which puts pressure and collapses the lung. So it's a little bit different there. So all those things, different lung problems, and it's not limited to those lung problems. Okay, any acute or chronic problem with the lung will cause problems, of course, with oxygenation. And then, again, we didn't cover a lot of cardiac disorders. That's not the focus of this course. But just remember that any problems with the heart is also going to affect oxygenation. Excuse me. So our assessment starts, of course, with vital signs. A focused cardiopulmonary assessment. So cardiopulmonary meaning heart and lung. Okay. So we'll listen to breath sounds in all quadrants. We will assess breathing, any use of accessory muscles, any shortness of breath, any activity intolerance, and then we will listen to heart sounds. We will palpate our pulses. We will look at our blood pressure and heart rate and respiratory rate. And then, did I say palpate peripheral pulses? I think I did. Okay, and so those will be three of our, those will be our main assessment parameters. Now, on blood pressure, your text says that it should be taken in 3 positions: lying, sitting, and standing. And that is not really the case. So when we do vital signs, we do blood pressure in the position the patient is sitting. Hopefully that is a sitting or lying position. When we do the 3 different positions, we're really looking for orthostatic hypotension. So if your patient has an oxygenation problem, do not be making them sit, stand, lie. Okay, you've got a sick patient in the bed. They've got an oxygenation problem. Assess their blood pressure in the position that they are laying in or sitting in. Okay, it's only if you need to do an orthostatic blood pressure that you will do those 3 different positions. Okay, you will auscultate an apical heart rate, or not the rate. You will auscultate the heart sounds, apical heart sounds, and then you will palpate the peripheral pulses. Now, when you get your heart rate by palpation, that is an adequate way to assess heart rate. Now, when you need to assess a heart rate through auscultation of the apical heartbeat, you usually do that when you have an irregular heart rate. Okay, so if you're palpating your peripheral pulse and you're detecting that the pulse is irregular, then you're definitely going to be auscultating that heart rate. The other thing that you want to, with an oxygenation problem, a lung problem, or a heart problem, you're definitely going to want to be assessing the pulse deficit. So if you remember, a pulse deficit is when you're auscultating the heart rate at the same time you're palpating your radial pulse. And what will happen is you will hear the heart beat, but you won't feel a pulse with that beat. That is a pulse deficit. So the heart did contract, it did create a pulse, but it contracted so weakly that you did not detect the pulse in the radial artery. That is the pulse deficit. So when you have respiratory problems in your patient, or you have cardiac problems in your patient, you should always be assessing for a pulse deficit. Now, for a patient that comes in for tonsillectomy, a patient that comes in with a GI problem, a patient that comes in with a fractured leg or whatever, you don't need to routinely assess for pulse deficit. Okay, so here is where you need to decide what assessments you need to make for your patient's presentation. So we'll also be visualizing respiration. So remember, when we did our assessments, most of the students, they were listening to heart rate, but they weren't they were listening to respiratory rate, but they weren't visualizing the breathing movements. You have to visualize the breathing movements in a patient who has oxygenation problems, because you need to see if they're using accessory muscles. You need to see if their breath, their inspiratory and expiratory movements are symmetrical, okay? So we need to be visualizing their chest. That means looking under their gown. Also, we need to be visualizing their chest and palpating, palpating for pain in those intercostal muscles, but also palpating around the heart. Okay, so a heart that's working harder, we might be able to be feeling bounding heart contractions by palpating around the heart. Also, we may be seeing asymmetrical chest size. So we need to be looking for all those things, okay? So palpation again, auscultating the heart rate, auscultating the heartbeat, and noting any abnormal sounds other than S1, S2, okay? Listening to lung sounds in all fields. If our patient has a cough, we don't just say, do you have a cough? And they say yes, and we say, oh, that's well and good. We need to ask about a cough. What causes the cough? Do you cough anything up when you cough? And if you do cough anything up, what does it look like? Okay, and then we may even need to get a sample of what they cough up and send it to lab, okay? The other thing we look at is, of course, we're going to be palpating peripheral pulses, so the radials bilaterally and the pedal pulses bilaterally. Okay, those are your standard peripheral pulses for peripheral circulation, is those two sites. Now, if you need to, for some reason, palpate popliteals, posterior tibials, then that's going to be something related to circulation to that area. Maybe they had surgery, maybe they had a trauma or something like that. But for normal peripheral pulse assessment, it is the radial pulse bilaterally and the pedal pulse bilaterally. Okay, and then in addition, we're going to be looking for edema. And if we find edema, we need to describe it. So is it just edema in the feet, or does it extend up through the ankles? Does it extend up through the calves? Does it extend up into the thighs? Okay, so we need to determine the extent or where that edema, how far that edema extends. Okay, we also need to check for skin color as well. We need to do capillary on the fingers bilaterally and on the toes bilaterally. So, of course, this didn't have it. So, in relation to edema, we need to also, so we need to say the location and how far it extends. We need to say whether it's pitting or non-pitting. So if someone has edema and you put pressure in that area with your finger and it doesn't, and you remove your finger and it doesn't leave a dent, then it's called non-pitting edema. But if it's pitting, then we need to say if it's +1, +2, +3, +4, and that is related to the depth in which you can dent and how long that dent stays there after you remove your finger. Now there's another kind of edema where the person is so edematous that their skin is so tight, it looks stretched, it looks brawny, it might even be seeping, okay? So that needs to be noted as well. All right, so we did pulses, skin color, cap refill. Some of the diagnostic tests we can do, there's a bunch of labs we can do, but these are pulmonary function tests. These will be done by respiratory therapy. These will be ordered by the physician. So here is a name of several of the different kind of pulmonary function tests and what they indicate. And again, respiratory therapy will be doing that. So the lab tests that we can draw, of course, are a CBC. We're going to be looking for our blood's ability to contribute to our oxygenation. So how many red blood cells do we have? What is our hemoglobin and hematocrit level? That will tell us about our oxygen carrying capacity. excuse me, and then what our white blood cells are, and will tell us whether we have an infection that's contributing to oxygenation problems. We will do a metabolic panel, which will tell us about our renal function, our kidney function, our electrolyte balances, whether or not those are contributing to cardiac function. Okay. ABGs, or arterial blood gas, those will definitively tell you what our patient's oxygenation status is. Okay, so it looks at pH, it looks at carbon dioxide, it looks at our partial pressure of oxygen in our blood, which is different than our oxygen saturation, and then it'll look at our bicarbonate level to tell us whether or not we have acidosis or an alkalosis, and whether it's respiratory related or whether it's metabolic related. Okay, something that they may do, especially if there's a significant heart factor in our oxygenation, is they will look at our lipid profile. So that's our HDLs, LDLs, our triglycerides, and total lipid panel. So please do know these norms. So your total cholesterol, please know what a normal total cholesterol is. Okay, so you want your total cholesterol to be less than 200. Your HDL, which is your high density lipoprotein, that is the good cholesterol. We want that to be greater than 60. Your LDL, which is your low density, we want that to be less than 100, and then your triglycerides less than 150. Please know these values, okay? You will need to know these values not only in this class, but in next semester adult class and in pathophys. So you'll need to know these. You will need to learn these and know these, okay? Now, cardiac enzymes. So if we determine that we have a heart problem, so they will order some cardiac enzyme tests. I do not require that you know the normal values of these tests. So if there is a problem with the heart muscle, then the heart muscle will secrete these enzymes, and these enzymes will tell us that we have heart damage. Okay, so just so you're aware what these are. I do not require that you know the values, the normal values. So other things that we can do, of course, if it's a heart-related problem, we can do a 12-lead EKG. We can also put a patient on a 2-lead. So those heart monitors are usually just a 2-lead, but then we can do a 12-lead ECG test, and I will show you what one of those look like. Of course, we're going to do an X-ray. We may do an echocardiogram that will show us the heart a little better, the flow of blood. I think I have a picture of this in some of the slides. So it's just a picture of the blood flow of the heart, and then we can also do a cardiac catheterization where they actually go in and evaluate the coronary arteries, the arteries that supply oxygenated blood to the heart muscle. So the ECG, the 12-lead, so that looks at the electrical conduction system of the heart. Okay, and this is what the tracing of a 12-lead ECG looks like. So you can see all the different leads, 1, 2, 3, 4, 5, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. Anyways, so this is looking at the electrical conduction of the heart, looking at it from all different sides of the heart, and it produces a normal waveform. And then if there is a problem with a particular part of the heart, then one of these waveforms will be abnormal. And so they'll be able to determine what part of the heart is having the problem based on this tracing. Now, this is just for so this is an electrical signal tracing of the heart. All these different waves. Here we go. Let me use my mouse. All these different waves correspond to the different S1, S2 beating and relaxation of the heart. So this is a normal one beat of a heart. This is what it looks like electronically. Okay. Now, if there's a problem with the way the electrical signals are being fired and the way the heart's pumping, these will look abnormal. And so there's probably 2 or 3 dozen different type of electrical tracings that signify some sort of dysrhythmia or arrhythmia of the heart. And there's usually, you can take a class as a nurse to learn all these different electrical tracings and what they signify or what arrhythmias they represent, which is not the scope of this class. Okay, of course, we can do the chest x-ray, and it will tell us a lot about the lung, what's going on in the lung, what they can see as far as whether they have pneumothorax or atelectasis or a pneumonia, things like that. They can also it will give them a limited picture of the heart. Okay. All right. The echocardiogram, of course, like I said before, it is like a picture of the blood flow of the heart. And here is so if this was colored, you would see the blood flow going through this picture of the heart. It would look red on one side and, of course, blue on the other side. So these are really cool if you have an opportunity to go watch a patient have one of these. All right, cardiac catheterization. This is actually where they can go in and visualize the coronary arteries of the heart and see whether or not one of these arteries has a blockage that's not getting oxygenated blood to the heart muscle. Okay, and so so they usually go in on the femoral artery or the brachial artery, and with their little catheter that has a little camera on it, and they just go through the heart. One of the biggest complications of this is bleeding, of course, infection. They can cause arrhythmias by doing this. But this is to visualize, and then if they do find a clot, then they can put a stent in or a balloon in, or decide that maybe they need to do some sort of more invasive surgical procedure. All right, so here are your nursing diagnoses. If you haven't finished those this week, these are good examples of some nursing diagnoses you can use. Okay, and then here are your patient outcomes, or your patient goals, sorry. All right, so what we can do as far as our nursing interventions is any patient you have that is having a problem with breathing, of course you want to put them in a semi-Fowler's position. The easiest way for them to breathe is sitting up. We can do the incentive spirometer, which we practiced yesterday in lab. And then again, like I said, if you do not have an incentive spirometer, then you'll just have these patients do deep breathing and coughing, which will simulate the same thing the incentive spirometer does. Hydration, so providing adequate hydration. Your patient may have an oxygenation problem related to fluid volume overload or congestive heart failure, where their heart is not able to handle the blood volume that they have. So we do actually restrict their hydration. So depending on your patient's problem, you need to know this so that you don't continue to overload them as far as PO hydration. And then as well, if you're doing IV fluids, they may be restricted as well depending on your patient's diagnosis. And then providing oxygen therapy as needed. Let's see, so oxygen, okay. All right. Moving on. Now, patients with COPD, they present a different problem. So these patients aren't able to exchange gases. Remember that your patient with emphysema, where they're getting fluid trapping in the lower alveolar sacs, they're not able to exchange oxygen and carbon dioxide. So these patients, so they're not blowing off their CO2. So their levels of CO2 in their blood are high, which is hypercapnia, okay? And then, so that actually, when we give too much oxygen to these patients to get their O2 sats up, we actually inhibit their breathing drive, their oxygen drive. So it actually makes them worse. So these patients function better on a lower oxygen saturation than what we're used to providing for patients. So we need to look at their blood gases and look at what their PaO2 is, so their actual oxygen in their blood. So remember, oxygen saturation is the amount of hemoglobin that is saturated with oxygen, okay? Whereas your arterial blood gases are looking at the actual content of oxygen in the blood. So it's lower. So we will see what those normal values are, but on your ABGs, your PaO2 or your oxygen in the blood is usually 80 to 100. That's normal. Whereas oxygen saturations, we want it to be above 90%. So it's a different reading. Oxygen saturation is how much hemoglobin is saturated with oxygen, okay? And then your ABGs are telling us how much oxygen is actually in the blood, okay? Or in your blood volume. So we worked with in lab the different type of, and Paul discussed the different type of oxygen delivery systems. The most common one we're going to use, of course, is the nasal cannula. And then there are oxygen masks. And there are several different kinds of oxygen masks out there. Your physician will order which one is appropriate for your patient. And they deliver different percentages of oxygen. So if you need higher oxygen content levels for your patient than a nasal cannula, you'll be using a mask. And there's different kinds of percentages of oxygens with the different kinds of masks. So there'll be the simple face mask that you can use up to the non-rebreathing face masks with the oxygen reservoir. All right, so when we do give oxygen therapy to our patient, of course, we're going to, your textbook says to wait 15 minutes to recheck your oxygen saturation to see if your oxygen therapy is adequate. However, if you have a patient in severe respiratory distress that has very low oxygen saturation levels, you will not wait 15 minutes for them to decompensate more. Okay, so this is one of those critical thinking opportunities where you can, your patient's saturation is 89, they don't seem to be in any respiratory distress, they're not complaining of any symptoms, and you put some oxygen at 2 liters, nasal cannula, yeah, come back in 15 minutes and see how they're doing. But if their oxygen saturation is 82, they have, they're showing signs of shortness of breath, they're diaphoretic, they're complaining of weakness or dizziness, you're not going to wait 15 minutes. So this is where you're going to need to decide what's going to be safe for the patient. But after you have initiated your oxygen therapy, of course, your documentation is going to include what flow rate you put them on and what their oxygen saturation was afterwards. Now, these positive airway pressure, there's several different kinds. So there's CPAP, which is the continuous positive airway pressure, and then there's the BiPAP, which is a bi-level airway pressure where the pressures are higher during inhalation and they're lower during exhalation, whereas the CPAP is a continuous, the same pressure in both inhalation and exhalation. And they require different types of devices to provide that. So you're not going to just be using a normal nasal cannula or a normal face mask. These are different devices that fit snugly onto the patient, either over their nose or over their mouth and nose. They fit snugly. There is no leaks around the mask, like you saw with the simple masks we were using yesterday. And then the last being positive pressure ventilation, which is different than the positive pressure airway pressure. Positive pressure ventilation is where you're using a bag valve mask where you're artificially breathing for the patient. And we'll be practicing that sometime next week. All right, here's more on the bag valve mask ventilation. You guys learned this in CPR. So this is where you're providing artificial breathing for the patient. We did cover a little bit the different type of nasal and oral airways and what the rationale was for using each one. Okay, and so here's just a little more information on those for you. And here is information about the endotracheal tubes or the tracheostomy tubes. Endotracheal tubes, which are look like these devices. They go in through the mouth and down through the airway. Okay, where the tracheostomy tubes, they go in here at this tracheostomy site. Okay, these provide artificial breathing for the patient, and this is, if you've seen any endotracheal tubes, there's lots of different kinds. There's long-term use ones, there's short-term use ones, there's ones that you need to use a laryngoscope and visualize to place them, and there's others that you don't need, the emergency kind that that you put in without visualization. So depending on what area you work in, you might use some of those. So you guys practiced with the tracheal airways this week, and how to change those out and keep those clean. So the other thing is that we need to be concerned with our patients is their diet, and a person with a cardiac problem, we definitely want them on a high fiber, low fat diet, and so we'll be instructing them on healthy options, maybe even referring them to a dietitian. Of course, we want them on a weight management or exercise program, but typically these patients don't have any type of regular exercise, so we need to find something that will work for them. Like if you get a patient that's 50 or 60 years old or older, 70 years old, and they've never exercised before in their life, and you say, hey, you have a heart problem, we need you to eat healthy, we need you to lose weight, and we need you to exercise regularly, they're going to roll their eyes and not hear another word you say. So we need to find something that works for them. Okay, they're not going to be going to the gym and doing strenuous cardio exercises. They're not going to be doing a lot of lifting of weights, but we could get them involved in some sort of walking program, swimming program. A lot of these local physical therapy places, they do have cardiac rehab options where they can come in and work out with people their own age, doing low impact exercise programs. So we need to get them lined up with appropriate exercise regimen for their age and their willingness. So all right, and if they are smoking, of course we try to get them to stop smoking or at least cut down. Now, medications, I'm not going to go over medications in this class, but I did list just some general medications that people would be on for respiratory problems. So, of course, antibiotics would be one if they had a respiratory infection, but bronchodilators, so for respiratory problems where they have, this helps dilate their bronchial tubes. We have mucolytics that will help dry up the mucus that they're producing. They could be on steroids. So there's all kinds of things depending on what their disorder is, the medications we can give them. So you'll be covering these in your pharmacology class, but here is just kind of a brief overview of what some of these medications will do for your patients. All right. Now, as far as cardiac medications, of course, if they have high blood pressure, they'll be on high blood pressure medication. If they have fluid volume overload, congestive heart failure, they may be on diuretics, if you've learned that yet. So this is medications to help them excrete some of their extra fluids. If they have electrical problems with their heart and have some sort of arrhythmia, so there's some arrhythmia medications that we can give them. And then something that you can provide in addition to respiratory therapy is chest PT, or chest physical therapy. So one of those is the coughing, deep breathing, the incentive spirometer, and then actual physical therapy for their lungs, which would be postural drainage. Now, you could put your patient in Trendelenburg position, like upside down, to help drain mucus from their lungs, but these people will not tolerate that. So turning them from side to side, having them lay back, sit up, doing some percussion on their lungs to help loosen and dislodge mucus can also help these patients. So you could be doing these therapies. So if respiratory therapy comes into your patient's room and does some chest PT with them, go in there in the room with them and learn how to do these different techniques, especially the percussion vibration that you would be doing on their lungs. You could do that for the patient throughout the day. This is something that we could possibly even teach their family members to do for them, especially if they go home and still have some issues, okay? This talks about the postural drainage, where you put the patients in Trendelenburg. Not a lot of patients tolerate this, so you might not see this very often. Paul did go over chest tubes with you, so this is for the patient that is having some sort of fluid or air pockets in their pleural space, so that covering around the lungs, and that creates pressure. If it's filled with fluid or air, that creates pressure on the lung and collapses the lung. So these devices, when inserted into that pleural space, help keep that drained until that heals. And we do need to practice sometime next week on a dressing change and how to manage these things on your patients, okay? Anticoagulant therapy, so for these patients that do have a cardiac problem, they are at risk for developing blood clots. So our therapies or our interventions also are going to be aimed at helping these patients, one, not develop the blood clot. So we've got to do our adequate assessments on their peripheral circulation. We've got to remember, we do not do Hohenstein, but we do palpate and visualize their calf for possible blood clots. But we will be using those either TED hose, so those really tight hose that you put, socks you put on patients, or we will use those sequential compression boots. So that's the boot we wrap around the patient's calf. We connect it to the machine, and it inflates and deflates, and that just helps keep circulation in the lower extremities. If at all possible, we definitely want to get the patient up and ambulate But if they're not able to ambulate, the TED hose or the compression boots would be your option. So we'll assess for the DVTs. These patients might be on anticoagulant therapy, so they'll either be getting oral Coumadin or warfarin, or they'll be getting an injection, a Lovenox, which is the sub-Q injection, or they might even be on IV heparin. Now, when we have patients, depending on what anticoagulant they're on, some anticoagulants require blood test monitoring, so that would be your PT, PTT, and INR. And that will tell us whether or not we are in therapeutic range for our anticoagulant. Okay, and then if you have a patient that is on anticoagulant therapy, especially if it is Coumadin, we will want to instruct them on a diet that is low in vitamin K. So vitamin K is the reversal agent if their Coumadin is too high and they have a bleeding issue. So we want to teach them about foods. Well, we want to teach them what foods are high in vitamin K, and so that they can avoid those foods. One, to not mess with their anticoagulant levels. But if a patient is having a bleeding crisis from an anticoagulant, then vitamin K is the drug we give. Okay, so I was a little too soon on talking about the TED hose or anti-embolism hose or the sequential compression devices. So those are things you're going to be using on patients, especially if they're on bed rest or not able to ambulate as often as they should. Otherwise, we want to ambulate these patients, okay? All right, so that is all for Chapter 38. And I will post this and then shortly followed by Chapter 39.